Our presenter for this evening is Professor Peter O'Sullivan. Peter is a professor at Curtin University, School of Physiotherapy and Exercise Science in Western Australia, and works part-time as a specialist musculoskeletal physiotherapist, managing complex musculoskeletal pain disorders and body logic physiotherapy. He and his team conduct clinical research investigating underlying mechanisms and targeted management of persistent musculoskeletal pain disorders. He has published over 190 papers with his team in international peer-reviewed journals, has been an invited speaker at more than 90 national and international conferences, and has run clinical workshops in over 24 countries. Peter's passion is translating research into practice. So without further ado, I'll hand proceedings over to Peter. Thanks very much, Peter.
Thank you very much. I want to start off this talk today with a case. This case was based on an interview with Norman Swan. It was a man who I'd seen a few years ago now, but it's a very typical case that highlights the dilemma that patients with back pain often present. And it's a very common story we see in clinical practice. So we could just play that audio now, that'd be great. Just play that audio now,
Years ago, I had my first back pain. It was as a result of sleeping on the floor at a school camp. Then it got progressively worse over a period of 2 years. I was seeking help from my GP and went through a variety of different specialists trying to find an answer for it.
And how badly was it affecting you?
Well, it was affecting all of my movement. I was very guarded in any movement that I made. I refrained from lifting, and it got to the stage where any sort of bending was difficult and was something that I completely avoided.
Were you in pain all the time?
Pretty much. It would get progressively worse as the day went on, so I'd wake up with some level of comfort, but by midday it was quite painful, and at night it was severe pain.
So it was knocking you around a fair bit?
Yeah.
What treatment were you having?
Initially, I started to visit my physiotherapist, but that would give me relief for a very short period of time and no ongoing benefits. Then I was referred to a surgeon who got me to get an MRI, and he pointed out the areas of my back that weren't looking quite right. There was some arthritis beginning, and there was some issues with the facet joints, but he didn't think that any kind of surgical intervention was actually going to give me much relief. So then he referred me to a pain specialist to get a cortisone injection, and I had 2 of those, and they were reasonably successful, but again only for a short period of time.
So this is a pretty typical story that you would hear with someone who's presenting, who might start off with an original event. And very often these aren't injuries. These are like insidious onset of pain related to some kind of occurrence of, in this guy's case, sleeping on the floor of school camp. And often you see this cascading process of trying out different treatments in a primary care setting, and then getting scanned and then getting a diagnosis. And often what we know about scanning now is MRI scans are very sensitive, so they'll pick stuff up, and that becomes a default diagnosis. In this guy's case, he had what's a very typical finding on a scan for someone who's in around 40 years of age, with degenerative changes, maybe a disc bulge, some changes in the facet joint, and he gets a diagnosis of arthritis. Then he goes down this process of seeing a surgeon who tells him there's nothing that can be done for his back, and he starts believing that he's got this problem of arthritis that he now can't control, and then becomes profoundly disabled. And this is a very typical cascading process that you see people become disabled and then defaulting through the system of becoming avoidant. He had then put on weight, stopped exercising. It was impacting on his work, his social life, and it had a profound impact on his whole well-being. Then you start thinking about this: how is it that you can develop pain from sleeping on the floor of a school camp that then goes on to develop this disabling pain disorder? How is it that you can have, this diagnosis that somehow starts changing your whole trajectory of life? When we start looking at pain from an epidemiological perspective, we see that pain often emerges quite early in life, and we've published a number of papers looking at epidemiological processes of pain developing often in childhood around adolescent, the adolescent growth phase, and then rapidly increasing to hit adult rates in the early 20s, and then setting a trajectory towards later life. And often this trajectory is also coupled with factors such as increased healthcare dependency and increasing disability. We see the greater burden of this carried in females rather than in males. So this is very typical in Australia and in the Western world. We see escalating in the practice of back pain, escalating MRI scanning for back pain, increasing opioid prescription rates for back pain, increasing injection rates and fusions for managing back pain. But if you compare the burden of back pain to other disorders such as circulatory disorders and respiratory disorders, the disability burden around musculoskeletal conditions and back pain has actually got worse. That we see greater chronicity and a greater disability burden. So in spite of this increase rapid increase in cost in managing back pain, we actually see that we're not doing a great job. The disability burden is increasing. And this is where we see a number of papers showing that this, in fact, of all health disorders, low back pain is the greatest disorder, the disorder for the greatest burden of disability of all health disorders. So we're dealing with a really big problem. Now, for a patient with pain who presents to us, as would be the case of Martin's situation, trying to make sense of why they have pain is very important. We look at this whole idea of making sense of pain can be seen from a health and illness perspective model. And there was a model called the common sense model first presented by a chap called Leventhal in 1980, and it's been applied to understanding back pain. And what it highlights is that when you have a symptom such as back pain, you fall upon things like common beliefs, social messages, context, culture, and your previous experience of pain. And this influences what's called a representation. That is your identity. What is it? What is the cause of it? What are the consequences of this problem? What's the timeline? What's the curability? How do I control this? Based on that representation, we will have a response. That will be an emotional response and also an action. How do you respond to pain? How do you respond to being told that you've got arthritis of your back? And then based on this action, you appraise whether that action's been effective or not. And so when we start looking at something like back pain, this makes a lot of sense. We look at contextual or the social understanding or cultural understanding of back pain. You ask adults in the population what they think about back pain. They have this understanding that they think backs should be protected by resting, by being careful or avoiding dangerous activities, by strengthening muscles, by controlling the posture. And this kind of fits that these underlying beliefs of pain are linked to injury and damage. And this is often reinforced by common messages given to people through scanning, that we see that we have this high prevalence of findings on a scan that often correlate very poorly with the perception of pain and the levels of disability. We give messages that backs need to be protected and you shouldn't bend your back to lift, which are not supported by any good research. And in fact, and we have these beliefs that you need to strengthen your core and you need to sit up straight. And these are very common beliefs in the community that are not underpinned by good research. They're often the beliefs of healthcare practitioners. They influence the advice we give people, but there's actually very little causal evidence for these beliefs. So we start looking at the problems with a pathoanatomical understanding of back pain. We see that pathology, or so-called pathology, is very prevalent in people without pain. We see that severe symptoms occur in the presence without pathology. We see that symptom severity doesn't correlate, or disability doesn't correlate with what you see in a scan well. We see that you can have positive outcomes despite the persistence of pathology. We see that 30% of people have persistent pain after fixing the pathology, something like a disc fusion or a disc replacement. And we also know that from a number of studies that actually scanning someone's back and telling them that their back is worn or they have a degenerate disc frightens them and can result in worse outcomes long term. If we look at contemporary understanding of pain, we see that there is a genetic predisposition to back pain. We see that pain often emerges around times of rapid change, so adolescence, a pregnancy, transitions from into retirement. So these times of rapid change, of social change, is a time where often pain emerges. How someone responds to pain, though, is influenced by things like their cognition, their emotional response to pain, their social environment, their physical environment, their lifestyle, and other health comorbidities. And this can influence things like structural changes or inflammatory processes around structures, motor responses and changes in the nervous system. And that highlights that often we can see in some cases back pain is not disabling. And in other cases it can become profoundly disabling. And so these factors at the bottom that I've listed become real targets for change because they can influence whether someone's pain becomes disabling or not. So when we look at things like cognitions, we know that pain-related thoughts like, my back is caused by a degenerate disc, or I've got arthritis, or it's dangerous to bend, or I've got to sit up straight, or future thoughts like I'm going to end up in a wheelchair, or my pain gets me, so like this big burden, and I've lost a confidence to move, and low levels of self-efficacy. We know that these beliefs about back pain and fear of movement and a loss of self-efficacy are highly predictive of levels of disability. And this tells us that disability is not just driven by pain, it's driven by coping responses to pain, fundamentally driven by our underlying beliefs of what the cause of pain is. Now, we as healthcare practitioners have a huge influence on the kind of beliefs that our patients have. And so common messages like you're disc degenerated and you've got a weak core can, to the patient, be interpreted that I'm vulnerable, I'm structurally vulnerable and it's dangerous to move. We know from qualitative studies that simple language like the word like chronic can have quite devastating impacts in terms of people's understanding or implications of that. Words like instability, people can interpret as something that's, that is liable to pop out and something you can't control. Simple language like your disc is degenerated or you have wear and tear in your spine can be interpreted as something's rotting away, that my back is crumbling. And so these kinds of language that is commonly used in clinical practice and you often see in relation to MRI scans can actually have a devastating influence around persons' beliefs that can then impact on their behaviours. And so we see that a lot of language that is negative can create fear and catastrophic thinking. Where there's an undue focus on structure, there's a belief that pain equals harm or injury or damage, that belief that activity, if it's painful, is harmful. This kind of language can frighten people and it can certainly lead to greater levels of disability, and this has been shown in a number of studies. So when we look at people who are frightened with low back pain and we ask them, what is the basis to your fear? For many, they'll tell us things like, my back pain is because I'm damaged, and that's been endorsed by my scan, and therefore I'm frightened to move, I'm frightened to go to work, I'm frightened to bend, I'm frightened to lift, and you start seeing that the behavioural response to this is often avoidance and disability. For another group, they're frightened of pain itself. So some people have a mixed view, but often people are just frightened of pain and the impact that pain has on their life. But if you look at factors like fear, which we know are big drivers of disability, they're commonly linked to a lack of controllability, predictability, and high levels of pain severity that just frighten people. When we look at profiling people with back pain, and this is based on some of our research looking at people with persistent back pain, we see a variety of profiles in clinical practice. But in a sense, what we see is that the more psychologically distressed the person is, the more likely they are to feel high levels of pain intensity. The more disabled they are, the more bothered by pain they are. They're more likely to report significant life stress events. They're more likely to report pain provocation with movement. They're more likely to report that they have distorted body perception of their back. They're more likely to be sensitive to palpation. And they're also more likely to report undiagnosed comorbid symptoms like tummy ache, fatigue, feeling run down, headaches, gut problems. So often these comorbid symptoms are commonly linked. And when we look in a clinical setting, we see some people with low levels of psychological stress, some with moderate, and some with high levels of psychological distress, which may be comorbid with mental health problems. Now, the greater burden of people with back pain fits with those with high levels of psychological distress, and these are often the most challenging patients for us to deal with in a clinical setting. So when we look at something like fear or catastrophic thinking, it's not just about the thought, but this actually has a physiological effect in the system. So fear can trigger, or pain anxiety can trigger a fight-flight response, which can activate the hypothalamic pituitary adrenal axis. That can influence things like your heart rate, your levels of muscle guarding, your levels of tissue sensitivity, your body perception, as well as immune changes in through the system that can feed into altered stress responses linked to central nervous system wind up in the system. So when we start looking at things, psychological distress, we have to understand that there are biological processes that will influence people's actual perception of pain. And there's growing evidence to show that this will also have an impact on things like behavioural responses. So common behavioural responses to fear may be avoidance or protective guarding. These are often specific to the perception of threat. For some people, it may be a posture like the inability to sit. It might be a movement like very commonly forward bending. It might be an activity like going for a walk or hopping on a bike or going into gardening. It may be a social setting, or it could be a work situation. So for many, it may be the avoidance of the threatening activity. For others, it's persisting with the threatening task, but they'll do it by protecting. And often we see this with the presence of high levels of muscle guarding. And there's good evidence to show that the more frightened the person is, the more they guard themselves, the more co-contraction that they will demonstrate. And so we often observe this in a clinical setting as people protecting themselves as they move. You often see this with people holding themselves braced. They'll brace off their hands to get out of a chair and hold their breath. They'll often prop off a hand, as you can see in these images, and brace themselves when they go to move. They'll often hold their back stiffly. If we look at systematic reviews of people with pain, we see that people with back pain move slower, stiffer, and with less variability. We ask people about what they're thinking when they move, and they'll often say things like mundane activities of daily living have gone from being unconscious to being planned, fearful, and threatening. And this has been demonstrated in a number of studies. And this is just one, for an example, a study that looked at people with back pain when they lift are more likely to co-contract their back, keep their back stiffer, and this results in higher levels of compressive loading forces on the spine. So in a sense, this protective guarding response can potentially be pronoceceptive. It can create more load on pain-sensitive structures that feed back into this loop that tells them that doing the activity is provocative and should be avoided. So when we start looking at this body-mind relationship, we see we can't separate the beliefs from the behaviours, and that the more pain a person has, the more disabled, depressed, anxious, catastrophic thinking, frightened, the lower their self-efficacy, the more co-contraction of the trunk muscles they have. And of course, this really contradicts historical views that you need more spinal stability for people with back pain, because in fact, people who are highly distressed and disabled with back pain are already co-contracting their backs more. They're bracing themselves as they go to do the task that threatens them. We look at lifestyle factors. There's growing evidence around activity avoidance and sedentary behaviours. Abdominal obesity and sleep deficits is having an influence on the nervous system, influencing things like inflammatory endogenous pain inhibition, circulating cytokines that can be pronoceceptive. Also changes in terms of the immune system. When we start looking at profiling people with back pain, we see at one end of a spectrum, some people present with relatively localized pain and movement hypersensitivity. These are people who are less likely to be emotionally distressed. They may have pain linked to posture, loading, movement, may have some issues with sleep and stress, At the other end of the spectrum, we'll often see people where pain is more widespread. You'll see disproportionate pain responses to low-level mechanical stress. So often in a clinical setting, the person might say, look, I just go and bend over 3 times, my back's in pain for 3 hours. So they have this disproportionate pain response. Often pain is less well-defined and more widespread. And these people are more likely to demonstrate cold and pressure hypersensitivity. When you profile these people, you'll see that they demonstrate high levels of anxiety, depression, catastrophic thinking, stress, and sleep problems. So we actually see different profiles are linked to these different multidimensional factors, again highlighting that issues around emotional distress and a clinical presentation are commonly linked. Now, in reality, you see a spectrum of these presentations in clinical practice. There's also evidence that when pain persists for a period of time, just the thought of a movement that is threatening can be provocative. In this study, this is a group of people who were in a functional MRI scanner where they were just observing these 2 lifting tasks. And when they saw the man lifting the box, a number of them reported the experience of pain and activation of cortical regions related to emotional responses to pain. Now, this kind of study is supported by a number of other studies that are emerging in the neuroscience world, that the persistence of pain is linked to embedded memories of pain, and that when someone develops an emotional response to pain or a negative emotional response to pain, that can set up central nervous system processes that can result in reduced endogenous pain inhibition and activation of the prefrontal cortex linked to emotional responses to pain, reorganization of the sensory motor cortex where there's a lack of precision around movement. You see this in the protective muscle guarding, activation of glial cells, amplification of nociceptive inputs, even in some cases a loss of grey matter. So the central reorganization of the nervous system is shown to be very predictive of the persistence of pain, much more predictive than things that we commonly look for, like what we see in an MRI scan. And this tells us something about the nature of pain when it persists, is that it's less likely to be something around the damaged structure, could be a sensitized structure, but there's a whole lot of change in processing in the central nervous system that is commonly linked to this kind of wind-up. So we look at Martin's story and you go, someone presents to us like Martin and says, look, I was sleeping on the floor of a school camp 2 years ago and now I've become profoundly disabled. How does that process occur? Well, there's growing evidence that for someone like Martin, that initial trigger of pain when he was lying in school camp and his response to that will be influenced by social conditioning, his historical interactions with maybe healthcare practitioners, his history of pain, contextual stress, levels of sleep and anxiety. And when I saw Martin, my first question was, what was your role in this school camp? What was going on for you in your life at the time when this occurred? And what transpired is that Martin was running the school camp. He was under a heap of stress. He hadn't been exercising the few weeks before he went to the school camp. He had a bad night's sleep, and he was a guy who didn't have high levels of self-efficacy. So for him, when he developed pain in his back and it felt very severe, he panicked. And so his first response was to go and seek care. And when he saw his physiotherapist and he had, like typical manual therapy, palliative approaches to treatment, and it didn't work, he worried more and went to see his GP. And typically, as is often the case, the GP referred him for a scan, and the MRI scan, of course, came back with these changes of a degenerate disc. And so the cascade then went to see the surgeon, who told him, yeah, that's the cause of your pain, and then injections weren't working, and he became profoundly disabled. So based on this process, Martin had this view that his pain was caused by damage. His pain was linked to a damage of his back, although it wasn't quite clear how that would have occurred with just sleeping on the floor at school camp. But he could see the evidence on a scan that he had arthritis, that his back was degenerated. He became his belief was that that meant he was going to become disabled. This was a life sentence. there was no cure for these degenerate discs apart from the thought of a fusion or a disc replacement, which he wasn't keen on. And so for this, the common sense response to that, if you've been told that your back's damaged, is to think, well, I better preserve that back. And if you ask patients who've been told that they have degenerate discs, they're thinking discs are like a car tire, that if you've only got one car tire, you don't want to drive that car too much. You want to protect that disc. You want to not load it too much. You want to make the most out of it. And so his common responses, which are really common, was to start avoiding stuff, avoid activity, avoid bending and lifting, avoid things that hurt him, because he was thinking every time he bent and lifted and he felt pain, he was doing more damage. And so his picture in his back is that this back was crumbling, and he was a guy of 40, and he was looking at his life thinking, God, where am I going to end up? And so, of course, for a person who thinks they've got a damaged back and they're avoidant and protective, and so his protective response is to extend his back, co-contract it, breath hold, tense it up and load it more. And of course, this feeds back into this pain cycle. From an emotional perspective, he had these very negative beliefs, but was very distressed. He was frightened to move, very anxious about his pain. He was hypervigilant. He couldn't stop thinking about it, and he had become quite profoundly depressed. Depressed that he had lost a lot of function in his life. A lot of the things that he loved to do, like ride a bike, play with his son, socialize, he had really lost that, and even his ability to work had become quite compromised. He had put on weight, and this was impacting on comorbid health things, issues around his blood pressure, his levels of cholesterol as well. So when we start thinking from a common sense model, it makes sense that Martin has done this, given the belief system that he's had. And this has then trapped him in this vicious cycle of pain and disability. So we start conceptualizing this multidimensional profile, and this is a Radiograph that examines issues around the dimensions that are important for someone like Martin. And if I just highlight this, ironically, even though he had a degenerate disc, you see in his case that this is not an abnormal finding for someone of his age. He's got he's highly sensitized around his lumbosacral structures. He's very emotionally distressed. He thinks his back's damaged. It's impacting on his social life. He's physically disabled, and this is also impacting in terms of his lifestyle, his ability to sleep, and his levels of physical activity, and his whole health has been affected. So ironically, the very thing he's thinking is the domain that probably is the lowest, and that's around his pathoanatomy, because there's nothing on a scan that would have differentiated him from someone without pain. So we start asking healthcare practitioners about how they feel about inquiring and dealing with psychosocial factors. We see that we're not often that comfortable with dealing with people's distress, and this was a qualitative study we published that looked at physiotherapists' views on dealing with psychosocial factors. And physical therapists said that they only partly recognize the role of psychosocial factors in pain, that patients with psychosocial factors are seen as more demanding and attention-seeking, that questioning and screening for these factors was considered to be beyond the scope of practice, and that physiotherapists lack the confidence in dealing with these kinds of issues. And of course, this is a huge problem for us in a primary care setting, because we see the greatest burden of pain is sitting with people who are most distressed. And I think one of the things that's important here is to understand there's a big difference between pain-related distress and mental health problems. Sometimes they coexist, but for many people, high levels of distress doesn't mean that they have a mental health disorder. They're just stuck in a difficult place and can't do the things that they want to do in their life. So this has impact on the way we would examine someone with pain. And we see the interview process being terribly important, that the interview we really consider around the story of the individual with pain, where we're interested in the history and the context. And so the history and context was really important in Martin's situation because he never had an injury. This was a pain event linked to this contextual stress that was happening in his life. His pain was relatively localized. His pain was clearly provoked with activities and movements that were related, ironically, to him holding his back in hyperextension. He was very disabled. He had these negative beliefs. He was highly distressed, and this was impacting on his social life. His coping strategies were around avoidance and protective guarding, and this was impacting on his social life. His goals, which he wasn't really clear on, was to develop some kind of control over his pain so he could get back to doing the things he loved. He really grieved the fact he couldn't play with his son, or he couldn't get out on his bike, and he couldn't go to the movies and socialize with his family and friends. Of course, screening is important. So we want to screen out red flags and certainly specific pathology related to so any progressive neurological deficit or quarter equine sign. So we must be very clear on that, although being clear that the majority of back pain doesn't fit in that space. From an examination point of view, many of the things that we typically look for in an examination are often not that predictive or helpful. But certainly one of the things that we look for is pain responses. So pain responses to things like movement, bending, repeated movement, and palpation, and analysing his functional behaviours. So the things that he reported he was most disabled with were things around bending and lifting, the ability to sit for any period of time. And so these are the things that we examined. They were the things that he was most frightened of. And so we go through these, what we call guided behavioural experiments, where we take someone back to that very thing that frightens them, like to bend and to lift. We modify his behaviour, so we get him to relax. We get him not to prop up his hands and hold his breath. We reassure him it's safe to bend, and then reassess what actually happens when we guide him back into these movements without him guarding and protecting his back. And often what you see is that there is a reduction in pain, and this confirms that bending should be avoided because it's unsafe. So this is a bit of a clinical journey, and part of this process is psychosocial screening, and there are some wonderful screening tools now around the likes of the Aurora screening tool and the StartBat screening tool. And these explore things like pain beliefs, fear avoidance beliefs, levels of anxiety, stress, and depression. And these are very helpful for clinicians to screen patients to identify high levels of psychological distress. So we must be clear on one thing, and that is that psychosocial screening is really dependent on the patients disclosing to us. If they don't trust us, and maybe they don't know us, or they don't want to be stigmatized as having a mental health problem, they may not be honest with those screening tools. So nothing replaces a good interview in terms of getting to the heart of someone's story. When we look at changing behaviour, it's very difficult in many cases, is that there are so many options in the health system that might be to deliver a drug or an injection or a passive treatment or massage or heat or kneeling or acupuncture that actually provides short-term pain relief that maybe doesn't take someone back on a journey to have control over their pain and get back to the things they love. And so when we provide too many palliative options in the care system, often it's hard for people to take the stairs. So when we look at managing someone like Martin, we look at their beliefs and their behaviours and look at trying to unwrap that from a common sense understanding to take people back on a journey. And this is very consistent with studies that have asked patients how would they know if they had recovered. And the common things that people talk about is having control over their pain. So this is just some common statements. Getting rid of the pain for a start, but if I could change anything, it would be the effect pain has on me. And this often reflects the emotional response to pain. Another example, there are good days, but if I have 2 or 3, I'm fine. I'm always happier than that. It's more about the quality of life. And so these things around quality of life are really important, or perception of controllability or controlling the emotional response that they have to pain. Functional recovery is critical. You know, things like just to go bushwalking, to do the housework, to stand, to cook a meal, or just to iron. Quality of life, to do the things I value, run with the kids, and that was very much around Martin's situation. He had no control over his pain. He couldn't do the things he loved, and that was massively impacting on his quality of life. So often we get focused on pain relief, but for a patient, it's the impact that pain has on them, the impact it has on their ability to function and their quality of life, which is so important. And that's the kind of journey that we take them through. So we see this journey as multifactorial. part of the journey is to sit down with the patient, actually try and help them make sense of their pain. So in Martin's context, making sense of the fact that how could he go from waking up from sleeping on the floor at school camp to becoming profoundly disabled over a couple of years? How does that make sense? So actually sitting down and explaining to him the multidimensional nature of pain and the drivers of disability to help him make sense of that process. Then taking the person back to the things that frighten them, but to provide them with controlled strategies to get back to the things they love. And then to take them back into changing lifestyle factors that are important and very much linked to their goals. So we see this as, to take someone on a journey like this demands a very strong clinical alliance, and there's really good evidence now that patients strongly value our communication and interpersonal skills. That is influenced by our levels of confidence, but also our ability to listen, just to be quiet and listen to the story, our empathy, our levels of friendliness, encouragement, our non-verbal communication, the ability to be quiet, to touch them, to reassure them, to care for them, to acknowledge their levels of distress, to highlight that it's normal to feel down and distressed when you've got pain that is a barrier to living. They also respect practitioner skills. They want to be educated. They want their care to be individualized, that we take their preferences into account. They don't like swimming, they don't want to swim. If they want to go cycling, they want to go cycling. So often we get too fixed in what we think is good for the person instead of saying, what do you actually want? Of course, they care for time, and often in clinical settings we're pressured for time, and that's a big issue as well as flexibility. So we see this first phase of this process around making sense of pain is linked to a personalized explanation of pain, validation of the person in their context. Often this does mean that we have to challenge beliefs gently, challenge responses to pain, set goals, and target behavioral change linked to their goals. This is important to use de-threatening information. That movement is good for the back. In fact, there's a paper that just came out this week showing that running strengthens the intervertebral disc. But often most people think if you run, you're going to wear your back out. This idea that if it hurts, it doesn't mean you're damaged, but actually to relax, breathe, and move normally often provides pain relief. That pain doesn't mean that you're doing more harm. That backs are really tough structures, and they could be trusted. That it's safe to bend and lift without protecting your back and guarding it. And that lifestyle factors like how much you sleep and how active you are and your dietary factors are really important factors that can really help dampen the system down. The second phase is taking people back to the things they love, but to do it in a way that provides them strategies of control and confidence. So this is about enhancing people's pain control during valued tasks. So we use behavioural experiments for this. So in Martin's case, bending over was the thing that terrified him. So we use a graduated exposure model to first put him in a relaxed position, facilitate lumbar flexion, take him back from a supine into sitting, and then back to the thing that he thought he couldn't do. So we target the things that hurt, are feared, or avoided. We look at normalizing body perception and movement patterns. We take away protective and guarding behaviors to build self-efficacy. As soon as people achieve this, we take them back into their daily life to integrate these new behaviors into their goals, the things they want to do. So in Martin's case, work in the garden, play with his kid, ride a bike. They were the things that he wanted. So this is like a graduated exposure model to reduce the sense of threat that these activities often present to people. In many cases, these patients are very deconditioned, so you need to integrate some form of physical conditioning and graduated progression into these processes. Then lifestyle change is the other part that often forms a part of this process of just basic things like sleep hygiene, graded activity based on their preference. So in Martin's case, riding a bike, setting those goals, helping the patient reach those goals and taking them in a confident way back on that process. So what's the evidence of this kind of approach being effective? There's one randomized controlled trial published in the European Journal of Pain a few years ago now that compared this cognitive functional approach, which is with a pretty traditional manual therapy exercise approach, which would be about mobilization, core strengthening, and physical activation. And this study looked at people across a 3-month period and then conducted a 12-month and a 3-year follow-up on these cases. And about 7 sessions were conducted over a 12-week process for both arms of this intervention. The patients in the study had persistent back pain that had lasted on average about 10 years. Pain was dominantly located between the back and the pelvis, and red flags and obviously neurological disorders or progressive neurology was excluded from that study. So the results of the study demonstrate, and the green is the manual therapy group and the blue is the cognitive functional therapy intervention, demonstrating that the CFT arm showed a significantly greater reduction in disability that was sustained over the 12-month period compared to the manual therapy exercise arm. Now, the manual therapy exercise arm did improve, and that's consistent with traditional or a number of RCTs that have looked at that kind of intervention, but the effects were significantly greater. It also demonstrated a significant reduction in pain intensity levels as well. There was also a reduced reporting of pain exacerbations, a reduction in fear, a reduction in the levels of distress, less need for ongoing treatment, and a significant reduction in the likelihood of taking time off work. In terms of satisfaction, 96% of people 12 months later were highly satisfied with the CFT arm of the intervention compared to the manual therapy exercise arm. And the interesting thing is the satisfaction increased at 12 months, well after the intervention period. And qualitative studies are telling us that that's because people feel like they're now in control of their pain problem and they're not dependent on people to fix them. This is unpublished data demonstrating that at a 3-year follow-up, the benefits that were demonstrated in the CFT group are actually maintained 3 years later. You can see this with very little drop-off at all 3 years later. So it looks like this effect can be enduring. There have been some other studies. This is a study that was conducted in a secondary care setting. These people were taken off a wait list to see a pain physician, and they were followed for 3 months, intervened for 3 months, and followed up. And this is Curtin O'Sullivan's study published in Physical Therapy. And 80% of these people never went on to see the pain physician. You can see large reductions in disability occurring over this period of time. And we have replication studies now that are occurring in a few different countries that are looking at the influence of this against other interventions and in other healthcare settings. Qualitative interviews of people who have gone through this intervention highlight that those who benefit from this approach endorse that they have a different understanding of pain. I'll say, I used to think my pain was related to the fact I had this degenerate disc, but now I understand that pain can be influenced by lots of things. How the stresses in my life, my levels of sleep, my levels of physical activity. I understand that things like how much I engage or how much I protect my back influence my pain. And they describe achieving independence. They report that they have control over their pain and they've got back to doing the things that they love and value. Now, not all people reported a great success with this intervention, and those who said it wasn't helpful retained strong biomedical beliefs. They reported that they believed that their back was damaged and they needed someone to fix it, and they were thinking that that may involve a surgical intervention. They didn't report control over their pain, and they still reported being disabled. So we saw about around 20% of people either partially respond or didn't respond to this intervention. So clearly this is not working for everybody. There were some who were kind of partial responders. They said, yeah, I kind of get that this is not just about the structure, but actually I haven't really got control over this thing and I'm not doing the things I want to do. Now, I'm just going to play you, or Jeff's going to play you the video, the audio clip of the interview of Martin after the intervention. You'll hear him tell his story. You'll hear him tell his story.
What he said to me that made the difference. He didn't really spend a lot of time doing what physiotherapists would generally do, which is manipulate you and move you around. He helped me to understand that the pain was ongoing because I had come up with new ways to try and avoid hurting my back. He looked at my MRI scan. He told me that the condition of my back was not perfect, but he had seen people with far worse backs who could live reasonably pain-free. And that was really encouraging to hear that.
It would take a fair bit of courage to stop guarding yourself like that. Tell me how you moved towards changing the way you walked and guarded yourself so that essentially your back was freed up.
Well, there were a few things. One of the first questions he asked me was whether I could touch my toes. And I attempted to get as close to touching my toes as I could. Probably got my hands to about my knees, and then I had to give up because of the pain. And over the course of that first session, he asked me to try a few movements and reassured me that they were going to be safe. And at one point in the session, he asked me just to sit on a chair and lean forward. And then he asked me to see whether I could touch the floor from a sitting position. And then he just told me to stand up. Then he told me to look in the mirror, and I looked at myself touching my toes. 5 minutes after, I couldn't do it. And I just broke down and cried. I couldn't believe it.
An audio clip.
Take before it was having a more permanent effect on you?
Well, for me, the effects were fairly quick. On my second appointment to see him, which was a week later, I had noticeably less pain. When I started to bend forward and use those muscles that hadn't been used for a long time, the effect was fairly instant. Even in a week, it was probably half the pain that I had before, and within a month, it was really reduced. You know, I wasn't feeling pain during the day, maybe a little bit at night if it was a tough day.
And how are you now?
Well, it's been probably about 6 months since my last appointment with Peter, and there's only been 2 or 3 times when it's been quite sore. And the difference for me now is I didn't panic. Pain used to make me panic a lot, but now the mindset's very different. I have pain and I think, all right, I need to do some stretches, and 2 or 3 days of getting back into my stretches, things seem to be back to normal.
So if we start thinking of this kind of report that we hear Martin say after going through this intervention, we see that his common sense approach to pain has changed. He's thinking, he said, my mindset's changed, that I don't now think that my back's damaged. I understand that pain is related to contextual factors, that my system can become sensitive, and when it does, I tense up, that I don't have to be disabled with this problem, that it's got a good prognosis, that I have management tools, that I can take control over this. Now, so he says I don't panic. So that's related to this change in emotional response. Pain used to make me panic. Now what I do is I stay engaged. I move, I get active, I do some stretches, and that allows me to get back onto doing stuff, and that breaks the cycle. And this is the kind of story that we're hearing in the qualitative interviews with people with pain, where they start taking control of their pain. They've got tools. They've got a different understanding of their pain, and they can break the cycle in a different way. So that journey looks like the storytelling, the understanding, the reconceptualizing of the meaning of pain, taking the person back through to build confidence to the things that they love, and impacting on things like their levels of lifestyle effects as well. So we start looking at his profiling beforehand and after. We see a major shift. His emotional responses to pain have changed, his beliefs have changed, he's socially engaged, he's physically engaged, he's not protective guarding anymore, he's changed his lifestyle, it's had a positive impact on his health. The only thing that hasn't changed here is around his anatomy, the bit that worried him. Now I can see with a whole bunch of questions coming up, a number of questions are emerging around scope of practice, and I know there's quite a lot of debate in the research world at the moment around scope of practice. Are we trying to be psychologists as physiotherapists? And no, we're not. I mean, I think when it comes down to it, it's understanding that for many people, they have pain-related distress. We know that pain can relate to depressed mood. We know that pain, when it is disabling, gets people down. We know that when you're in pain and you can't control it, makes you anxious and worried, that it makes you frightened. But this isn't necessarily a mental health disorder. For some people it is. And so where it is, we see with this major depressive disorder, major anxiety disorder, panic disorder, high levels of social stress, uncontrollable, distressing pain, that's when we work in conjunction. And we have great networks of working with pain psychologists and with medical practitioners around pain management and working with people with pain in conjunction with psychological intervention. There's a huge group of people that sit in that blue zone who are highly distressed, who are not being managed well in our health system, who don't require to see necessarily to see a psychologist, but just need confident, effective communication and activation and intervention to help them get back to the things they love. And the thing that's interesting from our data is showing that actually when you get people back to the things they love, you give them an understanding of their pain, you give them control over things that are important to them, their levels of distress decrease, their fear decreases, their mood improves. That's about getting people back living again. So, of course, there are limitations to this approach. It takes time. And a lot of our healthcare systems are set up for short consultations, not to take the time. But we're spending a fortune on people, treating them dozens of times rather than taking the time on a few occasions. Clearly, it needs a paradigm shift in our understanding of pain. There's a level of training around shifting the way you might operate with some. Some patients don't want to engage in a process where they take control of their own pain, but clearly we need a health system that drives them towards this. And obviously we need health practitioners with a mindset to engage in this kind of approach. So what are the health messages to take home from today's talk? Well, the first thing we believe is that we've got to change the narrative of back pain. The common belief in the community is that pain is related to damage of structures that you can identify in a scan. What we understand is that pain-related distress doesn't correlate well with levels of tissue damage. So changing people's understanding is critical because that influences and frames their common sense understanding. Communication is an intervention. Listening to someone's story, validating them, providing them health messages that are positive can have a hugely profound impact on someone's life and their life trajectory. Understanding that managing low back pain is a journey. It's not something about treating the pain at a point in time. That journey involves functional activation, understanding, education, taking people back to the things they love. It involves engaging in healthy lifestyle. Extinguishing protective behaviours that are so often endorsed by telling people to protect themselves, avoid pain, avoid movement if it hurts, co-contract their back, brace their stomach, core stability beliefs that often seem to be very reinforcing of protective behaviours. And then finally, targeting valued activities and healthy lifestyle, and of course, this needs a team approach. That means if the GP, the physio, the psychologist, anyone who's working with that person sells the same message, the patient's got a much greater chance of getting there. So just to wrap up, I want to acknowledge a number of people that I'm linked to in this research, both at our Curtin University, nationally and internationally. If you're interested in this work, we have a website called pained.com. We're also active on Twitter, promoting an evidence-based shift in understanding or cultural shift in understanding of back pain. So that's my talk, and that gives us a few minutes to take questions.
Great. Thanks, Peter, for a very informative presentation. We had to have a couple of questions that have come through. It is quite interesting when you think about all the factors that do influence people's experience and responses to pain. So a few questions have been brought up. We've got a question around how you use the Radiograph clinically to obtain the results for each area of the patient's life.
Yeah. So we have, on our computer system, we have domains that we rate basically, and that rating is based on a combination of psychosocial screening, interview and physical examination that essentially allows the clinician to make a rating of the significance of the different domains, and that's a shifting radiograph. So you may find someone who's got a really fixed view that my back's damaged and I'm freaking out and I'm physically disabled, or maybe they've got other health comorbidities. You know, they may have a comorbid mental health problem that is really dominant. but it just helps the clinician to say, where do I want to target my care? And that's a shifting target. So that will change over time. We find it really helpful for the clinicians to just have this big picture view on pain, and you can come back to it each session to say, now, where has this shifted? Where do I need to now put my priorities in terms of management? And if you get stuck on one of those domains, it may mean that you need extra help as well, that you need to then cross-refer.
Great. We do have a couple of questions wanting more information on cognitive behavioural therapy and acceptance and commitment therapy. Can you recommend any books or courses that they can do?
Wow. In terms of this work, and just to highlight that this kind of model that I'm talking about is really an integrated behavioural model. There's a lot of work out there around ACT and commitment therapy, and Kevin Knowles is a guy who's, if you track his work down, has written a lot of work on that. Cognitive behavioural therapy, there's a lot of work around that. Stephen Linton wrote a book. He's a pain psychologist that is available, people can access, which is a really nice book as well. He was the person who's strongly behind the fear avoidance model. In terms of this work, we actually have developed an ebook, which is an interactive book that's got patient videos embedded in it, and that's not yet available. That will become available later this year, and that will be posted on the Pain Ed website, and that's really to just help upskill clinicians around dealing with these different dimensions that they may not feel comfortable to manage, the kinds of questioning, the responses, how to respond to your patients when they're distressed. And I've saw some of those questions pop up of how you deal with patients' distress, and I kind of look at it, well, how do you deal with your friends when they're distressed? You listen, you acknowledge, you validate. That in itself is an intervention. You understand them. But the key things that are often driving the distress are that lack of doing the stuff in life that gives them meaning, the lack of controllability. They'll become targets of care.
Right. We probably do have time for one more question, but before we do that, just to let you know that we will pop a exit survey up onto a survey up onto your screen shortly, so that will come up. If you could fill that out before you leave tonight, that would be great. So we do have a question from Scott, who is an exercise physiologist with cognitive behavioural therapy training, a big fan of yours. He says, I've had cognitive treatment element as secondary to movement pattern retraining for some years, but I'm often concerned about the scope of practice issues in that, essentially in uncovering and discussing beliefs dealing with anxiety and depression. We are very much entering into scope of psychologists, as you sort of mentioned before. How do you see this issue of staying clear of patients' core beliefs? Yeah.
So I think if you're dealing with pain, with people who are disabled with pain, they will be distressed. That's just a fact. We know that the more disabled people are, the more distressed they are. So if you're dealing with those people, you have to acknowledge their distress. You've got to ask them what they're thinking, how it's impacting on their life. You can't avoid that. That's about good patient care. That's not about being a psychologist. Of course, the scope of practice issue is where that is the key for around cross-referral. But the studies, as I indicated, that we've conducted have not utilised the psychologist, and we've seen big shifts in terms of levels of distress, mood, anxiety, fear around these interventions of getting people back to doing stuff. And I think we need to upskill primary health care workforce around dealing with those core beliefs around distress, because these patients are going to ED, they're shopping for practitioners because their needs aren't being met, and that's because often their distress is being stigmatized as, that person's got a mental health problem, rather than understanding that that person's just in a difficult place with their pain.
Yeah. Look, there are a few more questions that we don't have time for tonight, so it'd be great, Peter, if we can get an answer to a few of them, and I can actually send that out to all the participants watching tonight. Sure. So sorry for those that we didn't get a chance to get to, but we will try and get some answers for you. So once again, I'd just like to thank Peter for a really great and informative presentation. Just to remind you, if you could take a couple of seconds to fill out the survey that's on your screens at the moment. Also, don't forget about our next webinar on Tuesday the 30th of May, which will be on common foot problems and presented by Professor Deborah Turner from University of Western Sydney. So thanks again for everyone that's come on tonight and watched the presentation, and thanks again, Peter, and have a really great night.
Pleasure. Thank you.
Thanks.